So we are at Pinnacle Integrative Orthopedics in Wichita Falls, Texas, and I'm a board certified orthopedic surgeon, but my goal has really shifted from focused on surgery for the last, for the first 15 years of my career to the last 3 years in this project. Our goal has really been to help people heal their joint pain naturally without surgery. And so we focus on regenerative therapies. We use functional medicine techniques to achieve that. And basically our goal is to lower inflammation, help patients live longer, be more active, and at the same time prevent what has become really an epidemic of unnecessary surgery in the United States.
So one of the things I've been reading about lately is that the biggest growth in knee replacement surgeries have been those under 60.
Yeah, bro.
And I know if you get a knee replacement, you're really not supposed to go running and jumping and playing basketball anymore. But what's kind of the longevity of it? Because really we're talking about joint replacement versus regenerating the joint with some kind of a cellular therapy. But what is the longevity of a joint, say, in your experience, once you replace, say, a knee or a hip?
We tell people, we have all these technologies, new technologies like robotic surgery and all of these, what we say are these big improvements, new materials that we're making joint replacements out of. But to be honest, to be perfectly honest, the longevity of joint replacements haven't really changed much since the 1980s. So, 10 to 15 years, or I've seen joints last 20 to 25, but I've seen them from the 80s. Like I've actually seen joints that long. These are in really minimally active people.
Yeah.
If you have a very active person who is going to come in and have a joint replacement and wants to go back to doing an activity like weighted hiking, where we do a lot of backpacking, or we're going to do running, hockey, impact sports, even like a lot of cycles, like if you're a big time cyclist, joint replacement is going to wear out with time. So we do see them wearing out 10 to 15 years, and it's a real concern, right? So, one of the biggest problems I see in modern orthopedics is that we're doing these surgeries in people who are younger and younger. And that means that we're going to be doing revision surgeries in people who are younger and younger. And I have a lot of reasons why I don't think that's a good idea from a metabolic perspective. As a functional medicine, I would say functional medicine fan and somebody who applies functional medicine in my practice, I don't want to see downstream problems, right? And we have so many downstream problems from things that we do that we're doing now. If we're doing surgery on people in their 40s with joint replacement, that's really hard to take back.
And I think that's a good point to lead into this, because like you say, a lot of people who are very inactive, they might be overweight and their knee goes bad and they want to replace it. And what do they love more, themselves or their money? Because quite frankly, the biggest obstacle to doing cellular medicine and joint, which would be stem cells or PRF or something, is the fact that it's not going to be free. Your insurance isn't going to cover it. And then we have to think about, what do you love more, yourself or your money or possessions? And the people that I think are the most active, that are exercising, that do want to ride a bicycle, they generally love themselves more than their possessions. And they should know there's an option for them. So let's kind of get into the nuts and bolts a little bit. Can you describe platelet-rich plasma, PRF, in regards to functional orthopedic medicine?
Oh, yeah, absolutely. So platelet-rich plasma, or PRP, and can I just comment just briefly? You just made an amazing point about the value of the human body in American traditional medicine, right? And you said, do people value their body or their money more? And I think it's really a shame that we've been sort of bamboozled and fooled by this insurance industry, this traditional medicine industry, into thinking that our body is worth only as much as a copay. Right? If I can't get it paid for by insurance, it's not something that I want to do. And I have patients who come to me and they say, oh, well, I'm 70 and it's not worth it for me to do regenerative therapies for my knee because I'm just going to die in 10 years. I don't understand. How did we get there? Right? That's just such a travesty of, just programming and brainwashing that the system has done to us. And I think that's a real shame. And so, yes, the challenge is that it's a cash option. And what we find is that people who do this they're taking agency in their own health. They're removing that control from this big corporation in the sky, like United Healthcare. Let's take away their control, and they're putting it back in their own hands. So when people are deciding to do these types of treatments at a clinic like yours or mine, it is to me, it's sort of the ultimate exercise in freedom, right? It's my body. I can choose what to do with it. I can decide whether to spend my money on a electric truck that may or may not be bulletproof, or I can do this. So I think that's an interesting discussion that we can certainly have more of. But as far as platelet-rich plasma. That's basically where we take your whole blood, a patient's whole blood, and it can be it's a fantastic technique. So we take that blood, we spin it in a centrifuge to really concentrate the platelet. The platelet's the part of the blood, as you know, that helps us stop bleeding. But not only does a platelet help us stop bleeding, but it also has a lot of factors that it releases into that local tissue that enhances local tissue healing. It's a massive anti-inflammatory. There's studies that show that PRP injected into a knee joint actually has an effect on the system. It has a systemic anti-inflammatory effect. We can see it in a SED rate. We can see it in our CRP. And so we take those platelets, we highly concentrate them, and it seems like the magic is at 10x, 10 times what's in a normal platelets patient's blood volume. And then we can use different formulations. So we can leave the white blood cells in there if we're going to do one certain type of procedure, that's really good for tendonitis, or we can take those white blood cells out and do leukocyte poor PRP, which is really great for joint. And then we can also use the other products of platelets. So we can do PRF. There's other types of formulations. We can do platelet poor plasma, PPP, which can be great for trigger point injections and muscular injections. So there's just a lot of versatility in the use of that type of regenerative therapy, particularly in what I do, which is manage patients with joint pain.
So getting back to that, when we're talking about, we're going to go a little bit more into stem cells and platelet-rich plasma. When you're talking to somebody about platelet-rich plasma, are you more likely talking about somebody with soft tissue injuries or somebody with mild arthritis? Like, what would be your typical person? Because a lot of times lay people are coming in and saying, what's the difference between a platelet and a stem cell? So maybe let's talk about when we might use platelet, not where it can be used. You can probably use it for anywhere, but where would be common uses for it?
Oh, it's fantastic. And do you want to talk about the difference between a platelet and a stem cell first? I mean, we could get into, you want to go to that later? We can get to that later.
That's a great point. Let's do that now. Platelet versus
okay.
stem cell.
So the difference between a stem cell and a platelet is a fragment of a cell, right? It's a little, so, in your bone, the platelets are formed and they come out, they break into fragments, and then they're fragments of a cell in your circulatory system. The fragments of the cell are there to help you stop bleeding. That's what we learned in medical school, right? Very basic idea of platelets. Turns out that they have a lot more functions, right? They do a lot more than just help you stop bleeding. But a platelet is basically a circulating fragment of a cell that will go to an area of injury and it will clump up. It has adhesive characteristics, so they stick together. Platelet is so fantastically amazing because it releases these local, you got a lot of local factors that it will release into the tissues to help with healing and inflammation. But then also we have a stem cell signaling function in platelets. It turns out that PRP platelets will actually signal stem cells. So the difference between a platelet and a stem cell is, one, a stem cell is an actual whole cell, and a platelet's a fragment of a cell, right? A stem cell is a cell in your body that can become other things. And we know of two places that we can get stem cells in the human body. I know that you use a lot of fat to create stem cells, right? We get stem cells from fat, but we also get very robust stem cells. We call them mesenchymal stem cells from bone marrow. And these are in the bone marrow are the types of cells that can become other things. Bone marrow is what creates our cells. So stem cells are essentially cells that can become other things, but they're a whole cell. A platelet, again, is a fragment of a cell that can't necessarily become other things, but can act as a signal to a stem cell, right? So that's what's really powerful about PRP. And your question was, where's the best place to use PRP? Well, that's a nuanced question. If you're going to use PRP primarily, there's some good places to use it. But one of the coolest things that I find with PRP is that it can actually enhance our treatment when we use stem cell. So when we're going to go in there and we're going to implant stem cells, if we pre-treat with PRP, the conventional wisdom is that PRP will actually stimulate those stem cells to deposit more accurately in areas of injury. So that's one of the functions of PRP, right? So cool. Like, the body's amazing. I don't know who designed this thing, but he's a genius, right? So the platelet can lay down in an area of injury, and then it says, hey, I need some help here. Well, then your bone can, or your fat tissue can mobilize these stem cells out into your circulation. And there's actually studies that show they've tagged stem cells in the system, injected them, and then they travel by themselves to an area of injury. So that's being signaled by, in part, by the platelets in the local soft tissue injury. So we can actually do that using our regenerative techniques. And so that's one of my techniques is I actually use PRP first, even in a more arthritic joint, because it makes stem cells more active.
Now, can you clarify when you say first, in the same procedure or on different chronologic dates?
Well, we have to be careful because it's not when we do, we're not allowed to modify the tissue, right? So, and there's some nuance there. You can combine PRP and stem cell, right? And that can be an extremely effective treatment all in one. But oftentimes we'll do a pre-treatment with PRP. So in our case, we do a pre-treatment with PRP, and we'll even do a post-treatment with PRP if the local soft tissues need it. But yes, I'll do PRP first and then come in with stem cells at a separate setting. So
Okay.
another appointment.
Just going along the same lines. So I want to ask you briefly about your thoughts on alpha-2 macroglobulin treatments
Okay.
for joint disease.
A2M. I think by it's one of those cofactors that PRP has, right? And we can certainly concentrate it. It's intensely healing. It's a potent anti-inflammatory, and it also potentiates some of the activities that we see in PRP, right? So cartilage redisposition, so reduction in inflammation, synovial infiltration, all of those things are reduced by that substance. It's naturally in PRP, and the idea is that we take that and we highly concentrate just that substance. And it can be effective. That's not something that I use a whole lot of, because in my view, if we get a really good dosage of PRP, if we're getting 10x and if we're using it like we need to use it, we don't necessarily need A2M.
Yeah, just my personal thoughts are pretty much aligned. I've read the studies. They do have some compelling nature to them, but not more so than PRP. In
Yeah,
addition,
no.
it's an expensive procedure to do. So I just don't know that the juice is worth the squeeze for A2M. So we'll just move past it. Anyways, A2M, just for the listeners, it's kind of obtained similar to PRP where we draw your blood and extract it. It's a much bigger molecule than PRP, or bigger tissue than PRP, and it gets injected in the joints. The idea is it's kind of sucking up these things called proteases or enzymes in the joint. So we talked about PRP and when you might use it. So kind of get back on that. So you're talking about pre-treating a person that has, say, bone-on-bone arthritis or arthritis. Talk about some of your uses for, say, hydrodissection of a nerve injury or like a carpal tunnel, or in my case, I had a subscapularis tendon, 70% torn. 7 years ago, or no, 2011. And Dr. Kehoe, he's an orthopedic doctor like yourself. I was his first case he did. He came to my office and we did it under ultrasound guidance. It completely grew back. I was actually scheduled for surgery and I never had surgery. So give me some of your experiences, maybe some anecdotal cases too of using PRP to heal things that people thought they had to have surgery for.
I think the best example, and for us at Pinnacle, it's not just that we're doing local joint treatments, right? We really focus on, our goal is metabolic optimization. In addition, I maintain that if we're going to use a regenerative therapy to heal somebody's joint pain, that it's going to be much more effective if they're optimized, right? And so we have a whole plan and a method on how to achieve that optimization and make our injections work better. But I have done, my PA's husband tore his quadricep tendon. He's a pilot, and he was walking around an airplane. He trips on the ice. He fell on his knee, and he tore his quad tendon. He had a 75% tear of his quad tendon. And in the orthopedic literature, it's recommended that we do quad tendon repairs if we have more than about 50% of the tendon. And he had actually torn his tendon on the other side about 5 years ago.
Okay.
And had to have it repaired.
Bad luck.
Yeah, bad luck, right? Right. One could say possibly there's a metabolic problem there that we can address. And for him, we actually did. There's a lot of things that we found in him. When we looked at him under ultrasound, I felt like we could treat this with stem cell, and he did not want to have surgery. So we put him in an extension brace. We treated him with mesenchymal stem cells. We did bone marrow aspirate. We did a PRP injections to start, bone marrow aspirate about 2 weeks later. And at about 6 weeks, I ultrasounded his quad tendon, and it was completely intact.
Yeah. Amazing it can grow back.
Just incredible.
My experience has been most notably with rotator cuffs, doing PRP right into the torn tendon, and it's like it seems 100. I mean, everyone say 100% effective. I think when it's not 100% effective, we didn't get in there properly because it seemed to always work. I had personally had myalgia paresthetica, which is actually kind of a rare orthopedic condition where the lateral cutaneous femoral nerve gets pinched in the inguinal groove, and it usually occurs in like people wearing like say cops wearing a belt and gun or athletes, and I'm kind of athletic. And I treated it back in 2015. It kind of came back about a year again and did a second hydrodissection with platelets, and it puts that under control where there's really no good surgery for that. So sometimes we're doing this to avoid surgery, and sometimes we're doing
Right.
it to treat things that there's really no surgery for. So let's get back into the stem cells, and you briefly touched on bone marrow stem cells, bone marrow derived stem cells, what we call adipose derived or fat derived stem cells. We do liposuction and get these stem cells. That's my experience. We do a lot of plastic surgery. You from orthopedics, you're used to getting into the bone. And then there's
Right.
umbilical or umbilical cord stem cells, which we buy from a laboratory that stores them. So can you kind of go into, I mean, I know we talked about this separately. That's, you can say there's difference between the two of them. But really the biggest difference is are you going to do surgery or not? And then what selection of stem cells you use might be based on who you're seeing because they have different abilities. Like we have an ability to collect fat, and you have to collect bone marrow. Give me your thoughts on the differences between the three products.
Well, to me, I love mesenchymal stem cells because I'm used to the bone, right? Like, but the harvest of mesenchymal stem cells, like when we do bone marrow aspirate, you got to get into the bone. So that can be a little nerve-wracking for people. We find that our patients really do not have a problem with it. It's a very powerful and versatile treatment, and basically what we do is a numb up an area of the pelvis here, and then we go in with a small needle and draw off about 180 cc's of the bone marrow and process it here in the office. It's really a pretty quick process. As you know, for fat aspiration, we have to do it's like a little bit of a mini liposuction. So you take some fat and then you process it that way. And then as far as allogeneic stem cells or stem cells from somebody else, right? Like Wharton's jelly and those types of things. Those are typically young stem cells or embryonic stem cells. And the idea is that they're very young, right? They're from cord blood or placenta or something of that nature. In my opinion, you need to use human. There are out there, there's bovine stem cells, there's porcine, there's like cow stem cells, and I've heard of pig and all of that thing. I don't have any personal experience with that. To me, that's a little funky, just because we have such great options for human derived stem cells. The the Wharton's jelly and those stem cells from other sources, they can be very powerful. I think one of the arguments against them, they have a lot of the growth factors, the same growth factors that we would find in other stem cells. I think that the argument is that when they freeze them, you may kill the cells. So the cells may not be viable or living when they're injected. My personal experience with IV stem cells has been very positive. At this point, we're really interested in using those types of stem cells to optimize the whole system and using a more focused bioactive for that particular patient treatment for the joint, right? So bone marrow or fat, adipose. And then you might say, well, in our older patients, are those going to be effective? Because you might have cellular senescence. You might have older cells that aren't as active. But what we find is that even in patients who are in their 80s, their stem cells are still working pretty darn good. They still get amazing and long-term relief. So to me, I feel like there's still great options for using a patient's own stem cells. I'm also very interested in the technologies that you mentioned, like that we can use from other sources, because not having to harvest is definitely a positive.
Yeah. So back, say, 10 years ago, the labs selling us the umbilical stem cells could actually say, we're giving you 10 million or 20 million viable stem cells. And the FDA and the FTC have said, you can't even say that. If you use that word, we will shut you down. So now they don't even report. So we have to go and get a laboratory evaluation of it because the FDA is really wanting to regulate this because there's not a lot of money for the FDA in these umbilical stem cells. There is a company called Cellularity, and they're going to have a placental-based stem cell product that will be FDA approved in mass manufacture. It's going to be crazy expensive, but I think that's coming. And their goal is to get it covered by insurance to make it more mass market. Going back to this thing, you made a good point about, older stem cells are still active. A case in point is your skin turns over every 30 days. So you have a basement membrane where there's a basal cell, and it turns into a squamous cell and into a keratinocyte. And every 30 days, that skin changed over. So if an 80-year-old person did not have active stem cells, they would run out of skin in 30 days and be skinless. So
Thank you.
we know they're still active. And there might be less active ones, so now they have wrinkles. But they still have a lot of active stem cells. And looking at comparisons to young and older stem cells, typically older stem cells are senescent, so they're not really doing anything positive or negative. They're sort of laying there. But we overcome that by we're using millions of stem cells, and nobody knows the sweet spot. But I've heard talk of about 5 million stem cells seems to be enough, and we're usually injecting 10 million. So if there's some sleeping ones, probably doesn't make a difference. You and I had kind of a talk about the differences. Like we know that there's more stem cells per ml in fat than bone marrow, but you're telling me, well, but some of the bone marrow stem cells are more active, and you think that not only neutralizes, might be in some way superior. You want to go into that a little bit?
Maybe that's, you know, I have looked at several studies that show very little difference in outcome between the two.
A clinical outcome, I totally agree with that. There is no difference. But,
Yeah.
when I wrote my book was in 17, I was kind of not bad mouthing bone marrow stem cells, but I was like, well, there's 500 times more. But it didn't take into consideration there's differences. A stem cells not like you have, hemopoietic stem cells, and you have, mesenchymal stem cells. We call it SVF, vascular fraction, which has mesenchymal stem cells. Probably like 2% of the cells are actual stem cells. But I think that we could probably agree on that. Is clinically, we're comparing this to surgery, not stem cell to stem cell. And we
exactly.
frankly have not found a difference. I've been using umbilical and fat drive stem cells. We have not seen a clinical difference between the two in 14 years. Now there's exosomes. And are you using any exosomes?
I have a lot of interest in exosomes, and we are currently researching how to apply that in the Pinnacle method. I mean, it's just a really interesting technology.
We found exosomes. I would say I've had experience in for about 10 years, and the exosomes work great in our business, which is cosmetic, where we're doing laser resurfacing in the skin. It works for somebody that's not bald like me, but it's got thinning hair. Works good for thinning hair. But we didn't find exosomes worked as good in the joints. So
that's been the common wisdom. Exosomes, in my understanding, are more of a vehicle. So what are we putting in the vehicle to get them in, to get them to cross barriers?
Even logically, if you think about it, it seems like it should work, but it didn't. And the reason we started using exosomes is that we were with Cell Surgical Network when in its early days. And we had our own lab where we made our own stem cells. So we basically would liposuction somebody, we call it harvesting the fat. And we put it in the incubator, heat it up. And then we'd add an enzyme called collagenase to break the fat cells loose to free up the stem cells. And then we'd spin them and harvest them. And then the government started saying, well, we think you're making a drug, therefore you've got to be a drug manufacturer. And they sued about 29 doctors, and they lost every time. And finally in Miami, they won a case. And that became the law of the land. Well, fat-derived stem cells, you can't use them with enzymes.
Right.
So we had to find other methods, and we did different methods to use it without enzyme. And then another doctor, Dr. Berman, who was the leader of the group I was in, sued the FDA, and he actually won. And then it became that was on again. And then when he passed away, the FDA sued back. There's nobody to defend it. So now it's off again. So what we're using now is a lab where we take your fat, we send it to the lab, they extract the stem cells under principle that's legal and allowed to do. And then they bank them for you for the rest of your life. We have to order them. That being said, you can take fat just like your bone marrow, but we can unprocess it and basically just break it up through what's called a Venturi device and inject it in the joint. It clinically works as good as stem cells, which is remarkable. And in fact, there's manufacturers, one's called Lipogems, which is designed just to basically process the fat to go into the joint. In the short term, it works as good as stem cells. And I think long term, maybe not as well, but it does work as well in the short term. When I say short term, 1 or 2 years of pain relief. So a lot of times what we'll do is give the patient that immediate relief by using this fat that's minimally processed in the joint, and then send the fat to a lab where they'll bank their stem cells, which is really cheap. It's $250 a year to bank the cells, and you got to pay to get them shipped back to you. Now, in your case, do you do any banking, or are you just getting more stem cells when you need them?
we haven't done any banking. The bone marrow is such a robust source of stem cells. I started into this space about 3 years ago. So I have a very learner's mindset. We're always adding cool new things, new better ways to take care of our patients. And that's part of what I love about talking to you is that I get to learn so damn much about about the space. Banking stem cells, I've actually just had a call with a company that they'll bank bone marrow too.
Yeah.
Yeah, so they'll culture them, grow them out, and then you have almost an infinite amount. So that's definitely something that I have been talking to patients about doing.
Yeah, so let's talk about
It's
that a
not
little
standard.
bit. So that because you say it's not that painful to do bone marrow aspirate, it's not. It's not that painful to do liposuction, it's not, but it's painful. So it's
Yeah,
not painful, and that is the more scary part. Injecting the joint is actually less intimidating. So I'm just going to give some terms that you refer to. You talk about expanding them and culturing them. So when you send the tissue, which could be bone marrow or fat, to the lab, they basically separate the stem cells from the rest of the tissue, and they identify these are likely mesenchymal stem cells. And then expanding means they grow them. So they could take, 1 million stem cells and turn into 100 million stem cells. And these can turn over almost indefinitely. And then they freeze them at 80 degrees below zero. And then they ship them out to you when you need them. So I think that's an option for people that if you're going through the bone marrow aspirate, it's not that expensive to bank them. And
yeah.
it's actually in our case, because we're doing a liposuction procedure, it's actually cheaper to bank them than go get them again. So that's
I think that's yeah, especially with I think Lipogems, not those kits are much more expensive than just bone marrow aspirate. We're not at the kits aren't as pricey for the
And to be
patient.
clear, when we're doing the harvesting, we're not using the Lipogems kit. So we're actually just using a syringe. So
Yeah.
it costs nothing in terms of materials. Just to
Oh,
be
that's good.
audience, the Lipogems is the name of the kit that you pull the fat up. It's got these basically like steel marbles in it. You shake it up and it breaks the fat up. We actually run it through a 3-way stopcock, saves the patient $1,100 and works exactly the same. So getting back to your ideal candidate, I liked how you talked about you're looking for people they're going to want to be active, and I think that's really really the main target for the early adopters for stem cells because if somebody's active, their orthopedic doctor is less likely to recommend a replacement surgery because then they got to tell them, hey, running is over, jumping's over, basketball's over. Um, we see people with minor arthritis to what's called bone on bone and kind of describe to the audience what is actually meant by bone on bone because sometimes people think there's nothing there to grow and there's maybe an X-ray finding or an MRI finding. Can you go over that?
So if we look at a patient with what we call bone on bone arthritis, when we look at an X-ray, we can't see the space, we can't see the cartilage itself, but we can see the space it makes. So on an arthritic X-ray, you would basically see a significant narrowing of that space to where the bone appears like it's touching on the X-ray, and that's what we call bone on bone arthritis. That doesn't necessarily mean that there is no cartilage to regenerate or to treat. It's just that it's extremely thin or extremely damaged. The bone surfaces are, and cartilage itself doesn't have good blood supply. It doesn't have good blood supply, so it doesn't heal itself. Once the cartilage is damaged, unless you do an intervention like a regenerative therapy or something happens, the cartilage is not going to heal by itself. I think that's important for people to recognize that arthritis is a progressive problem that there's a lot of factors in our own health that can contribute. We know that things like hormone levels, estrogen and testosterone levels can affect how your joint progresses. We know that different medications that you take can affect your arthritis progression levels. But when we get right down to it, arthritis is very simply just that the cartilage surface overlying the bone has been damaged over time and it goes away. Right? And the result of that sometimes can be that we can develop a deformity. So you see people who are like really bow-legged or really knock-kneed. And that in those situations, the bone actually remodels. In orthopedics, we have some big words. It's not too big. It's called Wolff's Law. Bone actually remodels along lines of stress. So if you push on it too hard, it'll remodel. It'll either get harder or softer. And in some cases, it gets softer. And so then you end up having the bony deformity that develops with arthritis.
Okay, that's great. I would like to learn about this myself for our clinic and our patients as well. So we have patients that have pretty straight legs, and we feel really confident. And then we have people with a severe, we call it genu valgus or varus, which is basically bow-legged or the opposite of bow-legged. They're kind of bent in knees. How do you manage the person that is bow-legged because of arthritis when they want regenerative therapy?
So there's a lot of different ways to do it. One, you have to tell them, hey, you have this deformity. We're going to do our very best to preserve your joint as best we can. But at the end of the day, if you have a severe deformity, regenerative therapies may not be as effective as you want. They almost always get some percentage of relief. Like I have done some, I've had people who come into the office and I've really tried to talk them out of doing regenerative therapies. I'm like, hey, we need to really think more seriously about having a knee replacement. Your knee's really badly deformed. And they go through with a biologics therapy and they do great. They get pain relief. But the problem is the research suggests that when we have a significant deformity, it doesn't last as long and that deformity can progress. It doesn't do much to slow down the deformity. What we do when we manage a patient with a big deformity, or when we have a pretty varus patient or something like that, you can put them in a brace, like an unloader brace.
Mhm.
The problem is patients don't really love to wear that brace.
That's
And they're
weird.
kind of coming to you because they want an option that's not going to really impact their lifestyle super like a whole lot. But a big brace is oftentimes impacts their lifestyle. So that's not often what they're looking for.
So, a common question I get from patients is how long is this going to last? And just to preface it, we've got PRF, which we might use as a standalone or as an adjuvant therapy. And then we have stem cells. We're talking really about PRF first. If you have a patient just doing PRF, the clinical studies show people get some relief for even more severe arthritis for about a year. So that can be repeated, obviously. And then stem cells studies have been all over the board. So what's kind of your take on how do you answer that question for people?
It's a tough one, and it depends a lot. One of the reasons why we are so focused on optimization, why we're so focused on the functional medicine approach, is it's my sincere belief that if we can get the patient healthier, right? If we deal with gut inflammation, if we deal with other things in the system, that these biologic treatments that we're using are going to be more effective and longer lasting, right? So that's one way we can cheat the system. The the party line for PRP is 12 to 18 months. We've had great success using our method. I actually do 2 injections between 3 and 6 weeks apart, and we have some other ancillaries that we do in there. And I've had great success out to 24 months so far with a lot of patients.
And you're talking about with PRP, PRF.
With PRP, PRF, and that's in arthritis. It's important to recognize that PRP can be a cure for tendonitis.
Right.
So if
Yes.
you have elbow tendonitis, if you have shoulder tendonitis, if tendonitis is the problem, then PRP may be the cure for that.
Yeah, and in my case, rotator cuff, the subscapular, 70% torn. It's been cured. It was
Yeah.
interesting. We got it done. I had read about it. It was brand new back then. Tiger Woods had it done and stuff like that. And I've had this orthopedic friend of mine come out and do it. And I sent my ultrasound tech to learn musculoskeletal ultrasounds. We were probably the first case in Michigan. And he told me, "Oh, we got to do it twice." And I'm like, okay. So we did it the first time. You could see that tendon was torn. And 2 months later, it felt perfectly normal. So he did it a second time. So he sticks that needle into a healthy tendon. Man, it hurt like hell. And the arm was stiff for a week. I didn't need to do it a second time. But this was 2011. It's 2025. It has been perfectly normal. It has been perfectly normal all those years. I'd have to tear it again,
Yeah.
basically. Yeah.
Yeah, I think you would. The other part of your question was stem cell therapy. So bone marrow aspirate, the initial studies that were done in France by Hernagal, there's studies that show that bone marrow aspirate can slow or reduce arthritic progression for between 6 and 10 years, depending on your overall health. There are good studies that he did to show that it reduces the need for knee replacement. He did a lot of work in the knee for the same amount of time, and that's even for pretty end-stage arthritis. So I mean, it's a really robust treatment. It works really, really well, and it's an amazing alternative to what would be a really invasive surgery.
So here's an interesting story you might not have heard about. There's a company, and they're actually NASDAQ listed, where they've got a patented process where they get bone marrow aspirate and they inject paraspinal, not intradiscal. They just published a paper on it, paraspinal, for lumbago or basically back pain, with or without radiculopathy, providing the people did not have more than 50% extrusion of their disc and they did not have spondylosis. And they had about an 85% success rate injecting in the region of the back, which is really, to me, just remarkable because we've been sending people for intradiscal injections and they just can't get in. But this paraspinal thing could be a breakthrough. And I remember telling my PA, Danielle, when she was working on hard joints like the hip, I'm like,
Mhm.
really, you just got to get it close. That shit works its way in there. You know? Whereas the knee is an easy target.
I like to tell my staff we want to get it in there. That's really important.
No doubt, no doubt. But there was an interesting
Totally.
step is that if you have a situation where you have, like, she had a patient with a labral tear,
Mhm.
it just bathed the area.
Absolutely.
You don't want to stick a needle in the labrum. But in this case of the paraspinal, I think that's very exciting. I'll send you the paper, but it was like,
I'd love that.
that's really compelling that you can just do a paraspinal injection and get back, because the back pain relief is such a difficult thing to deal with. It leads to so much disability and narcotic use and obesity. I want to kind of briefly go into this wellness aspect, and I think you're doing something that most, say, regenerative orthopedic doctors are not doing, which is taking care of the patient outside of their joint. So we can
Absolutely.
go into this. We probably could talk about this for hours. We're going to do like 10 minutes on evaluation and typical things that you see happen, and in terms of your intervention.
Oh yeah. Absolutely. One of the fascinating points that you just made on the spine, paraspinal injection, I think it's important, and you said it, right? Get close, because that's because stem cells will migrate. They go into different areas, and that's part of the point of using PRP or a signaler, right? If we bathe the joint with PRP, then we get those stem cells moving in the right direction already. So I think that's a really cool point. That's what's so powerful about them is we can inject them just into sort of a general area, and they can make a big difference for patients.
Okay, so I'm just going to segue on that. So PRP, we think about, and again, PRP and PRF are essentially the same thing. As
Same
PRP,
thing.
we're always activating it. But there's three growth factors that we really know work well in PRP. One is platelet-derived growth factor, which actually causes cells to migrate. So it's actually a
Yes.
growth factor that tells cells in the immediate area, which is your growth cells, your stem cells, to move in. And then it's got something called VEGF, vascular endothelial growth factor, which causes your blood vessels to start giving circulation to an area like the knee that doesn't have much. And then transcriptive growth factor, which has those stem cells that migrate in, turn into the proper cell. So the PRP is actually creating the environment that your own natural stem cells have a blood supply, can move into the area and start growing. And that's exactly how your skin heals when you cut yourself.
Yes.
So back into the, I get so excited about hearing about that because we get back into the subject of, I forgot what we were talking about. Oh yeah, about the other health stuff you're doing.
We're going to get to it. Don't worry. Yeah. In the Pinnacle method, we have developed a very directed but robust approach to functional overall metabolic health and wellness, with a real focus on helping patients with joint pain and longevity at the same time. So our goal is sort of hormonal balance, nutritional balance, gut biome optimization, and then environmental toxin reduction. So you want to clean out a lot of that stuff, and then we want to really support the system in helping us heal our joint pain. And very simply, I mean, it's not complicated. It's just never been done before. We're the only people that are doing it, and it's really great because I talk at conferences, and we talk about the Pinnacle method, and it just blows everybody's mind, and I'm saying to myself, well, I'm just talking about diet, I'm talking about mobility, I'm talking about things that can really move the needle, like bioidentical hormone replacement therapy. People, if you're not thinking about it, and you're in the age where between 35 and 65, it can change your life. It's changed a lot of patients' lives. For me, it's changed my life personally. And then we're learning more and more that patients are with low levels of hormones, like particularly estrogen, testosterone, are more prone to arthritic progression. So their arthritis gets worse, right? And there's even a diagnosis of perimenopausal pain syndrome. And in my opinion, fibromyalgia, this is often misdiagnosed as fibromyalgia because a lot of providers are so resistant to doing hormone replacement therapy, right? So we have to give them a different diagnosis. But it's been proven that low levels of sex hormones increase your risk of joint pain significantly. And it's not just one joint, it's a bunch of joints, right? So that's one of our tenets. And then nutrition. Mark Hyman says it, right? Food is medicine. It truly is. And we know that we can I have patients, when we start our process, we start them on an anti-inflammatory diet. I have many patients whose pain gets 30% better within 2 weeks just from starting the diet. Now, is that necessarily sustainable for most Americans? It can be really difficult, but it really optimizes our treatments. And so if we're coming in with a clean slate and then we're going to use your body's ability to heal to do just that, it just makes everything a lot better.
So that brings us into, I wrote a book on how we treat MS, which is a passion of mine because my grandmother and aunt had it. And we know that your own body's derived stem cells given intravenously seem to have an immunomodulation, or something that they settle down the immune system for about 9 months. And we always found their MS patients and other autoimmune patients, they get better for about 9 months after we treated them. But unless we dealt with these other things, and specifically gut health, hormone imbalance, and their diet, how they were eating. And I get patients who had rheumatoid arthritis or MS, and they got better for about 9 months, and they were kind of sliding backwards. And I find out they didn't really comply with the other stuff. So we, instead of giving them another stem cell treatment, we just kind of work with them. We put them on a little minocycline that actually is the only antibiotic that improves your microbiome. Mm-hmm. Put them on galactolignosaccharide and something like inulin or beta thylakoids to help their microbiome in their gut. Put them on women on testosterone and estriol, and men on testosterone replacement. Pretty much all men with MS have low testosterone. So do all women. And they start going to remission again. And that's not even considered. MS is one of the most expensive diseases you can get. It used to be it was rare to have a disease that costs more than $50,000 a year for medication. Now even psoriasis has $50,000 and $100,000 a year medications that really can be managed with the microbiome, which there's no money in it. So doctors aren't even talking about it.
So why everybody, why does insurance not want functional medicine to be covered? Right? Why can't you get these tests with your insurance? And that's the reason, because insurance companies are much more interested, because they're insurance companies and pharmaceutical companies. You can almost consider them the same entity. Many of them are owned by the same investment firms at this point, right? BlackRock is invested in a lot of these companies across the board. So the reason why these treatments and these tests are not covered is because they can make a lot more money charging you $50,000 a year or $100,000 a year for a rare drug, right? Like a drug for a rare condition.
Yeah, and a little known fact is the Affordable Health Care Act, so-called Obamacare Act, had the 85-15 rule, which is insurance companies can only keep 15% of the premiums. The rest has to go to pay for the patient's health. If insurance premiums come down, they're out of business. Insurance. Right. So they're really diseasing companies. So that, and I'm not bad mouthing. That's just, Congress set this up. Congress designed it that healthcare had to go up. And I think even unintentionally, they wanted so that we'd have eventually universal healthcare, because once the insurance companies go bankrupt, there'll have to be a public option. But I'm not sure a public option will want people to be healthier either. Medicare definitely has interest in healthcare savings, but they're in the same machine everybody else is.
In my opinion, it's sick care in this country. It's cyclic. You have to. It's always after the fact. I can't tell if it's on purpose or if it's just a really stupid mistake. But basically, the whole system is set up for you to have a problem before you can have a solution, before you can have a treatment, right?
Well, let's look at the insurance industry. Your car insurance does not check your pressure of your tires or your windshield wipers, or make sure you change your oil. And your house insurance doesn't check your CO2 monitor or fire monitor. So they might require you to have it, but they're not going to pay for your batteries and your smoke detector. And health insurance was designed to cover catastrophic financial losses. It was really never designed for health.
Right.
So in fact, with the Obamacare or the Affordable Health Care Act, that was the first time screening tests were ever paid for. A mammogram was not a covered entity until the Obamacare came out. There was about 52 preventative tests that were the first step forward in terms of preventive healthcare. And I'm not necessarily a fan of insurance companies paying for everything, but I would think that I would consider, what could you save money on? So with insurance companies, if they started paying for, say, stem cells and joints, the number of people seeking treatment would go up 20x if stem cells were free. Because then people would have a lower threshold and they've got to consider that, because they know if you do a knee replacement, there's a 2% major, morbidity rate, and there's about 20% of people still have some symptoms afterwards. So you got to think about it. I mean, you did court consults with your patients. Like, don't jump into this if you're pain, if we're not going to have a huge improvement in your quality of life. And
Yeah.
if you lower that bar, then everybody's going to want it done, and then insurance companies would be footing the bill. I mean, right now a good example is these GLP-1 agonists, the drugs like Ozempic and Wegovy and Zepbound for weight loss. Everybody wants it. If insurance covers it, everybody's going to use it, and then the cost is going to put a pressure on them, so people are paying out of pocket.
I think another way to look at the surgery, I mean, it's really interesting because we're doing more orthopedic surgery in this country than ever before. We're doing more joint replacements in this country than ever before on younger patients. So, and interestingly, orthopedics is one of the most profitable specialties in a hospital system, right? So even though Medicare's lowering reimbursements have gone down by almost 30% in just a matter of 15 years for orthopedics, it's still very profitable for hospital systems. And the majority of orthopedic surgeons now are employed. So 80% plus are employed. Whereas when I came out, I think I was one of the 20%. I came out and became employed, and was employed for 15 years. So what we've seen in my career, we've seen this major shift from trying to do more conservative management in a younger patient to actually doing surgery early. So the first thing that you said was that we have a lot of patients getting joints really young, and that's a problem, right? Up to 35% of joint replacements done in the United States are done prematurely. And so that's a real issue. The question is, why is insurance so willing to pay for this very expensive joint replacement and not for a probably less expensive regenerative therapy that's going to prevent the joint replacement? And in my opinion, part of it seems to be that there's a really robust hospital lobby, and these equipment companies have probably a pretty robust lobby as well, right? So there's a lot of impact that those multi-billion-dollar companies can have on our political system.
Well, I mean, if the PRP and PRF was not so easy to make and insurance covered it, it'd be 5,000 an injection.
Right.
5,000 injection. It said it's really much cheaper than that. Um, One other thing I wanted to get into, and I'm kind of lost my train of thought with it a little bit, but again, back when you talk about why do they have to cover, again, there would be a much bigger market for everybody getting it done, versus a few people getting it done. I want to talk about young people having this done. I think I lost my train of thought. I should have made a note. Um, Oh, one other question on my list of things to ask you. After somebody has stem cell treatment with bone marrow aspirate or stem cells from the fat, what are you telling them to do? What's the recovery period? What are we recommending they do afterwards in terms of activity, mobility, that sort of thing?
It depends on what we do. So we actually do osteoplasties with bone marrow aspirate. So you actually can inject it into the bone. Oftentimes when you have some of those more severe arthritic joints, the bone where it's, you were talking about the deformity.
Yeah.
The bone on the side of the deformity will have a lot of inflammation. If you get an MRI, you can see inflammation in the bone. Well, that's microscopically fracture. And so we can actually heal that and reduce that pain very significantly by injecting directly into the bone in those areas. That's something that's done really frequently. In those patients, we slow them down a little bit more. It can be 4 to 6 weeks before they go back to their full activities, but they can put as much weight on it as they want starting the day we do the procedure. In the case of bone marrow aspirate or PRP, if I have a really active person, I want their joint to sort of calm down, right? Because part of our problem is inflammation. And so we ask them to refrain, like to do an exercise program with mobility for about 4 to 6 weeks before they go back to their more normal activities. I have a whole protocol that we use, and it can be up to 3 months before they go back to their full activities. But the benefit is they have no downtime. Right?
Yeah, but they can go walking afterwards. They can go.
Absolutely. And walking, you can jump in your hot tub. Hot tub is actually excellent for bone marrow aspirate and PRP. Any regenerative therapies is going to respond better to heat than cold. So there's a lot more safety involved with the regenerative therapies that we do. There's a lot less, complication risk, lifestyle risk with these types of treatments versus a major joint replacement or major surgery. And honestly, I did 15 years of orthopedic surgery, and I found myself spending a lot of time in the OR, sort of looking critically at something that I was doing. And I'm like, am I really making a difference for this person? I've put this patient on the table. I've induced an anesthetic, which has a risk of death, right? I mean, it's really safe to do surgery in the United States, but like it's a non-zero risk,
Right.
right? And then I'm doing this surgery on somebody who, either habits, lifestyle, conservative management could have made a huge difference in them, and they wouldn't have had to be here having this torture that I'm going to do to them. And now they're going to be tortured in a sling for 6 weeks, and I've got it's 2 years before their joint's as good as it's going to get. It's just on and on, and that's if they don't have a complication. So it's my life's work to get regenerative therapies and a combination of regenerative therapies and this sort of metabolic approach to musculoskeletal care into the consciousness. I want more people caring more about the patient's whole health. We get into you said it, there's a lot of regenerative doctors out there who don't really do much focus on whole health. The maximum sophistication I've seen of a couple of the guys down in Dallas are they give them a supplement that's actually says stem cell supplement. Well, it's got resveratrol in it. and some omega-3s and NMN, which doesn't absorb through oral means usually anyway, so that's not a really great supplement. And then it's got like, I don't know, a probiotic, lactobacillus. So
I was at a men's event, so men's of our hospital back when we were allowed to have men's events. It was like a smoking thing with the guys. And I was working in the hospital at the time, and I was telling them how I had my shoulder done with PRP and a heel back, and I was interested in stem cells. And this is 10 years ago. And I was sitting with some orthopedic buddies of mine. They're like, well, I just hope this doesn't catch on before I retire. And I was thinking,
yeah, right. Like, well, yeah, I'm trying to get it to catch on early. But
they were thinking like, I hope this doesn't happen because I make a living on replacing joints. And not worry about their wellness and not worry about their health and not worry about their obesity. I can send them somewhere else, get medically. I mean, the classic story is the orthopedic doctor sees them. Okay. I remember what I was going to talk to you about. Here's my favorite line of all. Well, I've seen my doctor 5 times. He's given me 5 steroid shots. He says it's just getting worse. What the hell did you expect? You're injecting a joint with something that prevents healing.
Absolutely.
And it's going to get worse. And really, if you do 2 or 3 steroid injections, basically all it does, it hastens when you need a joint replacement. And that's been a modus operandi. I think it's even considered not appropriate to do more than a couple of times. But we hear that all the time. They get a steroid injection every few months. They do these HA injections. They have some benefit, but not much long term. But it's sort of like the orthopedic doctor gets a patient, they do a couple of steroid injections, failing. So now they've never talked to them about their weight or their lifestyle. They send them to a family doctor to get medical clearance. They see they're obese, maybe see them to a cardiologist, get a stress test. It's normal. So now nobody's talking about what they're doing, about inflammation, about their lifestyle. They decide you're not having a heart attack, you can have surgery. They get the surgery done. Maybe a nutritionist sees them and they feed them crap at the hospital.
That's awful.
So I send them home and they're right back in the same lifestyle. And then the other knee goes bad.
Right. It's a never ending. I mean, it's a never ending sort of recurring problem if we don't get to what we call the root cause. Right. So if you're going to spend your whole life working against your body's metabolism, then what do you expect? Of course you're going to have problems with any type of thing that you're going to regenerate from. Surgery is an intense regenerative procedure. Like if you're going to have a surgery, you want your body optimized so that sucker can heal. Otherwise, you're going to have a huge problem. And if you have a problem from a joint replacement, it is not a short-term problem.
Yeah.
There are no short-term problems with joint replacement that I can think of offhand. It's like you break around it, you're hosed. It gets stiff. It may stay stiff forever. If you get an infection, oh, that's really bad. If you just get tendonitis, it doesn't go away because it doesn't heal around a joint replacement. Our lack of, and this compartmentalization, right? I'm an orthopedic surgeon. I don't want to talk to patients about their health. That's irresponsible. It's created by a system that rewards us for doing high volume, not high value, right? High volume surgery is what we're going for when we're in the surgical specialties. We want to do as much as we can for as long as we can. And to your friend's point, I hope that doesn't happen before I retire because I make a living replacing joints. So what do I do in my office? As an orthopedic surgeon, I see you, I give you a steroid injection. You made an excellent point. Steroid injections are the devil as far as I'm concerned. We are injecting your joint with a toxic substance that can help you with inflammation, but immediately starts damaging your joint. It immediately starts damaging the tissues around your joint, and it immediately starts damaging your metabolism, right? Because it gets out into, I mean, it has systemic effects. Ask a diabetic. If we do more than 2 or 3 steroid injections in a calendar year, that's considered irresponsible. And yet we are doing it all the time.
All the time.
All the time. I have seen patients that are like, yeah, I get my monthly steroid injection from my ex.
Yeah.
From my doctor, from my nurse practitioner. Such a bad idea. So basically, you're just dissolving your joint in crap like the whole time.
They're getting cataracts now. They're getting
Yes.
vascular necrosis to their hip. I mean, there's all these other complications. They're putting weight on. They're getting fat. They're retaining water.
It's horrible. And that's typically done in a person who is less than optimally healthy anyway. So you're taking a person that's already compromised and you're giving them a medicine into the joint that not only damages the joint, but damages the rest of their health. I mean, what the hell? We've known since 1951 that joints, when we inject a steroid into a joint, that it damages the joint, right? We started doing them in 1948. We're still doing them. And it's because it's cheap. And I think because we as physicians like that feeling of, I helped you with your problem, at least for today.
They definitely get better for a week or two.
They feel better. And that makes me as a doctor feel really good. All right, I did this thing. You feel better. Okay, well, it's typical of human nature to sort of kick it down the curb, but kick that can down the curb. But the problem is we're getting you feeling better for a short amount of time, and it gets shorter every time. And it's damaging the joint.
Yep.
And it also increases the risk of complications so that when you go to have a knee replacement, if you've had a lot of steroid injections, your risks of complications are much higher statistically.
I didn't think about that.
We don't even do joint replacement. It is not recommended to do a joint replacement within 3 to 6 months of a steroid injection because of the increased risk of infection. Now, when we do a steroid injection into the shoulder, which is the second most common joint that we do steroid injections for, we damage the tissues there because we're putting it into soft tissues typically. And if you've ever had a painful steroid injection into your shoulder, it's not supposed to be painful. They probably injected your rotator cuff. So They injected your rotator cuff directly with a substance that's damaging it out. Yeah. And it's eating it. So it's turned into mush in there. So it's so bad. In the shoulder, if we go and do a rotator cuff repair, within 6 months of a steroid injection, it's been shown to have a much higher risk statistically of failing.
This is way before your time, but when I was in medical school in the 80s, it was common that some of the old-timer family doctors would put their patients on oral steroids chronically.
Oh, we still have it. I still have it here.
They wind up just dying 10 years early. I mean, it was just amazing how it ravaged their body, and they couldn't come off them.
No, because your body becomes addicted. You stop making the substances that steroids suppress.
Yep. You can actually die stopping it. Yeah.
Yeah. It's such a bad idea. It's such a sacrifice of people's health for this short-term gain, long-term loss idea. It's like American politics. We can't do anything in the long term because every 4 years we're changing what we do. It's even worse in medicine because it's a 6-week window. So I got to do something that's going to help you feel better for 6 weeks, right? Because then you come back to the office, I can give you another one, or I can do this other BS thing that just masks your problem. And I think that's the power and the wonder of regenerative therapy, especially when we combine it with actually changing the way a person looks at their health. It can make it's actually sustainable. It's long-term. It looks down the road. It improves the patient's health outcome, right? Our goal is to have that golden decade, the last 10 years of your life. 80% of Americans spend most of the last 10 years of their life in the hospital. That's bananas. If we can follow some very simple principles, if we can make some changes, if we can start that now, and it's never too late, then we can make that last decade of life like it is in Sardinia, where, people are in their hundreds still hiking up those mountains. It's not a mystery how that's done. It's just really hard to do it in America.
So this was a great talk. I really enjoyed it, and I'll look forward to seeing you next week and stop by your office.
Awesome. Yeah, absolutely.